What about the lordosis? No, why is no? See, we should do that. I say, where is lordosis? And say, and you say, what is lordosis? And another one says, why is lordosis?
Okay. Ooh, what, where, when?
Like the Guardian of Galaxy or that,
Yeah.
I think, who is Gamora? Why is I do it one better?
I haven't seen
So
the movie.
we are live, I guess.
Oh. Hi guys, thanks for joining. This is Essence of Medicine. Today we're going to be discussing what is lordosis. I'm Amanda Armagast.
I'm Melissa Haber.
And I'm Dr. Abbasi for Essence.
So Amanda, what is lordosis?
It's a word I see a lot. I understand that it's a curve, the curving of the spine, and I know it's a big drama on LinkedIn. A lot
It's
of
a drama, lordosis is a drama.
It's a big drama.
I
on
think
LinkedIn.
I'm catching up. Someone explain to me what drama's going on LinkedIn.
Well, when Dr. Abbasi posts his cases on LinkedIn, he's usually talking about how great the patient's feeling, the patient's doing so much better, their pain is gone, they can walk again, and stuff like that. And most of the comments are saying, what about the lordosis?
Now, it is very important though, because I just put a talk from a scoliosis surgeon out there that he goes through what the complication of spine surgeries for regular open fashion surgery. What do you guess what is the complication rate of a regular scoliosis where they do correct the lordosis? What do you think what that rate is?
17%.
40 to 70%.
Oh, wow. I knew it would be quite a bit, but
No, this is I put out there from experts. 70%. The new old result was 40%. The new result just published in 2016, 70%. 7 of 10 patient have complication after that kind of surgery that does correct the lordosis.
Yeah. So it went from 40 to 70?
It seems that based on studies and so on, that's not unusual for the result to be varying in medicine, but based on the expert opinion that I just put on LinkedIn.
Do you want to shout him out? Do you remember who it was?
Well, no, it doesn't matter. I mean, you look it up. This is a common information.
you know who you are.
Well, the complication rate for regular scoliosis surgery, where they do correct the lordosis, is 40 to 70%. 4 of 10 to 7 of 10 patients who get that kind of surgery, you correct their lordosis. But this is can be a devastating surgery.
Yeah.
And now, obviously, that is not option is not being given to borderline sick people because
The option of scoliosis surgery.
that is 40 to 70% is among the people who are able to get that surgery.
Right.
These are not the sickest
healthy
patients.
ones.
Healthier ones.
So before we continue, I want to, for people that don't know, what is lordosis?
So let me put it this way. We are one of very few living beings that walk on 2 legs.
Yeah.
Most of the animals walk on 4. And naturally, as well, when we are born, our spine, actually, like most of the animals look like that.
The fetal position.
Yeah, the
crunched in.
baby's spine look like that.
Sure.
When we grow up, our spine changes so that in the front, in the bottom part, it bends forward. In the chest, it bends backward, and in the neck, again, it bends forward for us to be able to be upright and walking. The forward bending of the spine is called lordosis. The backward bending of the spine is called kyphosis. So lordosis, kyphosis, and then again cervical lordosis. Okay. Now we know that you need that kind of dynamic for the muscle to function properly. By the way, this is normal for the spine in an adult. But if you look at the front, it should go straight up and down. Any going straight up and down in the front view is normal. Any side bending is not normal. We call that scoliosis. But let's talk about lordosis. So we know from lots of studies that this proper curvature is necessary for function of our spine. And if the curvature is not good, then it can cause problem in the past. Now, talking to actual scoliosis surgeon who have been doing it for 30 years, like Dr. Kim, is that these studies are all done for when you are treating younger people who are going to live another 50 years, 40 years, and so on. And you have to correct most of that from top down.
Correct it, meaning
Like-
to make it curved or
No, make that, this curvature is accordingly, and the angle between the spine and the pelvis, we call that pelvis tilt or pelvis index. These angles have a, the optimum angle. There's an optimum angle there, and that's true.
yeah.
But and we started doing scoliosis cases, obviously not for 50, 60, 70-year-old people. We start doing scoliosis for young people.
Yep.
Right.
Well, as we kind of talked about previously, like when do most people typically develop scoliosis?
Well, no, people can develop scoliosis
At any
any
time,
time.
correct.
But we treated only that for juvenile pediatric people who are going to have a lot of, and one of the reasons we started on those people, these are younger people who can afford with their body resources, with their health, to have that. Nobody would dream to do this kind of surgery on an 80-year-old or 75-year-old, because remember, 40 to 70% complication rate on healthy people. Okay, so now, but what we figured out on this data comes from usual scoliosis cases, which are younger people who have 50 years to live, and for open surgery. These are the 2 points. From the data on younger people who can get the surgery and have an open surgery, we know that these angles have to be on certain point if you do a big surgery. So 3 points: younger people, open surgery, top to bottom.
Okay.
And these numbers have been established to have an impact on the outcome. Now, what has happened in the last 7 to 10 years actually is that people who understand really very little of this kind of material, they transfer those results, those data. Now they say, it doesn't matter what kind of surgery, it doesn't matter what age, and it doesn't matter if you fix all of it, or even if you fix 2 or 3 of them, you have to correct those numbers to have the end results. End result meaning that, really help the patient. So based on those numbers on younger patient, up top to bottom, and open surgery, they created those numbers as an indication that the outcome is going to be good or bad. And that exactly applies to those group of people, the top to bottom correction, open surgery, younger people. Now, they say that a 75 or 80-year-old person who get only 2 of the levels fixed instead of all of that, with the minimal invasively, you have to apply as well the same parameter. Like, how much, I'm going to use an analogy. I cannot do but use an analogy. How much gas your car uses?
How much gas?
Yeah, but how
20
much?
gallons.
No, well, no, how many miles can you drive for a gallon?
Oh, about 300
Okay.
miles per gallon. Or per gallon, 36.
Yeah, I was gonna say,
Sorry, on the
what
tank.
car
I
are
was
you
talking
driving?
about a tank.
Okay, so you can drive 35 miles per gallon,
Right.
okay? But my car drives only 14 miles per gallon, okay?
Your truck.
Yeah, that's the way it is. Now imagine I tell you with your the 15 gallon that probably you put in your car, you can drive 100 miles,
Okay.
which would apply to my car, but not to your car.
Right.
And that is truly the misunderstanding of mostly these young people coming from the university, and just few famous surgeon that just put something out there. Nobody really, it is like a propagating kind of intellectual lie. That's what it is. They take the data, misappropriate it, bastardize the data, go from one group of patient to another group of patient in 3 different levels. Few people say that, everybody else repeat that without really looking at the data. There is a talk that Dr. Kim and we have, and we talk about it very openly. This data, they do not come from a limited surgery, and there is no data on MIS patient that have that surgery. So it doesn't even apply to them. And now Then I put the data of one of my patient who have been told by 3 surgeons.
No.
I just did that
Right.
surgery yesterday. You and I, we just rounded on that patient. I want
Yeah.
you to describe how was that patient
Are
doing?
we talking about our ACF? or-
No, no,
or
our
which one?
surgery that you did. We rounded on our
Yeah.
patient today morning. We are talking about scoliosis, not ACDF,
yeah.
right? So tell
Yeah.
me, tell us about
Oh.
the surgery that we did yesterday.
Yep,
Tell us about the patient, because you and I
Yeah.
together rounded. We did the surgery together.
yep, we did about it was
Alyssa.
a 3-level surgery lumbar fusion.
How long did it take us to do that surgery?
Hour, 6 minutes, or was it?
Yeah,
even
actually
under that? It
30,
could have been under that.
63 minutes.
63 minutes.
What
Okay.
was our blood loss?
67 cc's.
Actually 56 cc's.
Okay, well, you already know this.
No, I want you,
I knew about the range.
I never forget things about my patient. This is how obsessive I am.
I'm not sure I ever found those numbers out, but I
Yeah,
did a
yeah.
pretty good
No,
job.
Yeah, yeah,
no.
yeah.
I did a pretty
No,
good
no,
job.
but so on a patient who's elderly,
Yeah,
we did a-
70s,
that patient was actually closer to 80.
80s, yeah,
So we did a 3-level fusion. We corrected scoliosis
yep.
on a
with a
surgery that
Scully
was a
case.
little more than an hour. And we lost about 56 cc of blood.
What is that in relative, like, what is that relative to for people that don't understand that?
Well, 56 cc is like 1/5 of a cup of coffee. Whereas in a regular surgery,
Mhm,
you can lose easily 20 times more,
Easily, yeah.
easily. And then, and that patient, walked yesterday, walked today. Describe our exam today.
Yeah, no, today everything was great. Had full strength, was moving up and eating, was, easily it's like, hey doc, how's it going?
Yeah.
Smiling, normal conversations, for people that experience pain or see people with pain. Sometimes getting a casual conversation isn't even an
Mhm.
option.
Yeah. yeah.
This man was able to tell us, how'd you sleep?
Mhm.
How'd you sleep? Did you get to walk? Yeah, I was up and walking. I didn't have that leg pain anymore.
Yeah.
There was a lot of body mannerisms that we were able to tell, like, he's doing really good.
And most importantly, this is a patient who had cardiac problem
Mm.
that anesthesia would have,
Never approved.
even if the other surgeon would have done the surgery, the anesthesia would have never approved that. And that anesthesiologist and I, we have a good rapport.
Mm.
And I told him, it's your decision, but I'm going to tell you statistic. This is a 1.5 hour surgery. It wasn't. It was a
wasn't,
1
it
hour
was
surgery.
less.
It
Yep.
is 150 cc of blood. It wasn't. It was a 56 cc of blood loss.
Mhm.
And he said, okay, let's do it. But he told as well, very loudly, he never comes so close to canceling a case like this one. But this patient, luckily,
Mhm.
got the surgery. The pain in the leg is gone, is ambulating. 1 day after the surgery, this elderly patient, after scoliosis correction, will be discharged home.
Yep.
Compared to that, 40% to 70%
Complications.
complication rate. Now, I will put those films out there, and somebody is going to
Mhm.
come and ask us,
What?
what about the lordosis?
Yeah, exactly. And then you can tag this video.
There you go.
No, and the travesty of that is, they're so fixated on a number, reduced. Like, my question for that patient was, what are you trying to achieve?
Mhm,
I want really just be able to walk again.
mhm.
And that patient is walking today,
Already.
one
Yep.
night after the surgery. I want to be able to do my basic daily activity. Traditionally, we have lots of data within weeks, not within years, like open old-fashioned surgery, they return to life.
Yep.
And now the question will come back,
What about the lordosis?
what about the lordosis? Now, I can't just tell you that patient doesn't give a damn about lordosis.
At all.
No,
Doesn't
they
even probably
definitely-
know what that means.
No, but
They
even
do
if they
not.
understand that, some patients do
Oh,
understand that.
yeah.
But mostly as well, these are patients who have been told by those lordosis obsessed surgeons they have been told by lordosis. This is how we.
That's, we don't want to name.
No name, but people, this younger surgeon who all they care about to correcting a number in a person,
And it's
we
the
call
same,
them lordosis.
it's the same surgeon who wouldn't have touched that patient probably.
Yeah,
And
but
then
then-
also the same surgeon that comments that you always say, well, come learn my technique and see why am I not
Never
correcting?"
interested, never
Yeah,
interested.
they're too busy focusing on like how to comment on other people's.
Yeah, and this said, no, I'm okay. I'm a big boy. I can take critic and so on. But some of these patients, they literally gather their pills to commit suicide because they go to 5 surgeons. They're told there's nothing we can do for you because the goal is not really listening to the patient to see what are you trying to achieve. I'm trying to walk. I want to be able to do my take care of my hygienic needs and so on by myself.
Yeah.
This is what I'm trying to do. I'm trying to participate in family life. But the goal of the surgeon is to correct the lordosis.
Is there ever a benefit of correcting the lordosis if it's like maybe if you're in a minimally invasive surgery?
No, see, again, we have the data that in the data shows it helps the patient to correct that, but you have to go backward and look at what is the patient cohort, what is the patient population where this data is originated. Like, again, on open surgery, long stretch fusion, and younger population. And this is an important factor. The same way that I can tell you on my car with 15 gallon, I can drive like 200 miles or 70 miles. That in no way really applies to a different car.
Right.
Now, they think car is a car is a car, and that is really academic laziness. That is literally not really even going to background. It is like you see something on Twitter and just you retweet that without going back. Is it true what
Yeah,
I'm...
you're not checking your facts.
You are not checking your facts, and it is...
It's
and it
honestly a
has
little
impact on...
sad because
Oh, it is
everyone that's
in the lot
in the
sad.
healthcare field knows more than anything that every single person is different. You know, you can't compare a book to a patient almost in any situation. It's
So-
so customizable,
So,
you know?
and that's even sadder because when you try, like imagine the angle is wrong.
Mhm.
Let's say it is. Number one, we have a lots of data that angles with the age, the optimum angle with the age actually changes. We know that.
Yep.
Now, they try to create that angle to the time patient was 15 years old, whereas it is better to create that angle just before the time patient had symptoms, meaning that 5 years old, patient is 80 years old, okay? If they want to create that angle to the time patient was 20 years old, you have to break every single level to make it happen. Whereas if you want to change the angle to the time just before patient had symptoms, you have to correct much less. The data is out there. Again, academic laziness, not going and looking, not going actually reading the thing, just sitting somewhere in a conference and listening to a big name that says either you create deformity or you create deformity or you correct deformity, meaning that either don't do nothing or break every single level to create the spine that patient had when the patient was 20 years old. More importantly as well, the amount of the damage you need to do to create that angle, literally, there's something we call osteotomy. Practically, with lay term, it means breaking the bone in as many levels as needed so we can create that thing. Imagine, I don't like the angle of your arm. I have to break it in 5 different places to give it the angle I like.
Yeah.
Doesn't matter if you can use it. Doesn't matter, what I
To make
consider
the images look good.
treating the images rather than the patient. That is a travesty,
Does
actually.
this speak to at all the natural history of the spine? Because you talk a lot about how your spine is at its like optimum when you're like 12, 14.
Yeah, let's talk about that. Obviously, our musculoskeletal system has a optimum age. That optimum age comes from 2 different factors: our strengths and our strengths and our coordination of and these are 2 different factors. But if you look at this competitive sport, you find indication for that, what that optimum is. Like, when is the age group that our Olympic gymnasts are
Young, 17, 16.
much younger? 12 to 16 is the
I think you have to be
optimum.
14 to be in the Olympics.
Yeah.
Yeah.
So that is the optimum age between 12 and 16 to have optimum truly elasticity and
Flexibility.
and strength and so on. But you don't see football players in that age. You see the football players in their early 20s, right? Why? Because you have to as well coordinate them. The maturity in your brain and coordination lags always behind. So, but practically, you have the maximum of the musculoskeletal between those two ages. After that, just going to go down.
Yep.
There's no question about that. Now, creating data that is produced for that group of people and making it elderly, even 50-year-old, to create those kind of situation, because we just get the data from those younger people and now apply to the older people, that sort of requires us to do those horrendous osteotomy, literally, that we have names for them, okay? And everybody who does that is so proud that they can do those osteotomies. Some of them, we cut the back of the bone in multiple places. We break them. We take a chisel, we break them, and then sometimes we have to go cut a wedge into the bone
To create that angle.
to create the angle, okay? Now you understand why the
Complication rate.
40 to 70 is coming from.
Yeah.
We break the back sometimes in tens of places to create the angle that we think is the right thing, right angle. So to make the picture look good. Now, sometimes it's necessary, but you have to apply that to the same group of patients where the data is originated.
In what case would that be necessary?
That's just the thing. I'm gonna tag on to that because I had seen a patient similar, except for it was major kyphosis. And then, of course, you start to see some respiratory issues from the spine. And if you remember, kyphosis is on the thoracic, so it kind of inhibits your breathing because you're like this and it causes other problems, which is why managing the kyphosis, in my opinion, has more, it makes more sense because the benefits.
But there is not the obsession with kyphosis like with
No.
lordosis.
That's why Amanda was asking kind of, so what is a situation where you would have to, because I kind of know some situations where kyphosis deformities would be unnecessary correction, but as for
kyphosis as well, we know that, you remember we talked about that. There's a certain bending here forward that makes it optimum. There's as well a certain level of bending in the chest that makes it optimum. And we can really compensate for a lot of it. But if you bend too much forward and your lung cannot extend.
That's about what it looks like.
Yeah. But and that is, I don't believe there's as much controversy there, the kyphosis than in the lordosis. So we haven't seen a lord kyphosis yet.
No.
I'm sure we will.
They'll start coming out.
So are there any specific like
In the I mean in a patient now, and that is even get better. The reason that correcting this in younger people is going to be good for them is that we know in the long run is going to be helping them not having future problem.
Sure.
And now when I get that question on an 85-year-old person that says, okay, you fix that, patient is walking, pain is gone, but what about, now this is what I got. Are you concerned about the long-term results
of this
85-year-old person? And I just have to shake my head and say, what is long-term result for you? Because I have been doing it now for 10 years. And my answer was within 6 to, I've been doing
You're
it
gonna
for
get
6 to
me
7 years.
here.
I know.
Good thing I'm not as involved in LinkedIn because I just can't even get behind that because we talk about how ambulation is one of the most important steps after surgery. And if you go through and you do all that fixing and all those complications, what is going to be delayed?
Are they so when they say that, like when you're doing a small case and they say that, are they genuinely expecting that you should have?
Yes, that's exactly what it is. No, so this was exact post on the LinkedIn. This was an elderly patient for 6 months, couldn't walk. This patient could not go to the kitchen, get food, lost 40 pounds within 3 months. By the time we did the surgery, she was 105 pounds. It was practically bone and skin, okay? And it has pain, 10 of 10 pain. We did the surgery. within 1 month, patient was, and I put the data out there. This is open book.
This is your LinkedIn post
Yeah,
about your
yeah.
Scully patient. Yeah.
So within 1 month, patient is off narcotic. Patient hasn't walked for, I mean, I will put a testimonial. Please add it to this thing, to this podcast.
You get that, Charlie?
Yeah. So within patient stays just about a week in the hospital, which is
If you saw
unbelievable by
if you saw
itself.
the images, you would understand
Yeah.
why. Yeah.
And then 1 month after patient is off narcotic, after 3 months, patient is finally walking. She hasn't walked for 6 months, has not walked for 6 months before the
Mhm.
surgery, losing condition and so on. Patient, it was even then, that was a hard recovery. On a surgery, that was about 2 hours, and we lost about a cup of coffee of blood. And now I put it out there, and I really expecting people say, what is the technique you can do that? What is the infection rate, which is 0.3%
Mhm.
comparing to 20%, 15% for open surgery.
70%
No, well, that
for
70%,
lordosis.
no,
Yeah.
that 70% is more than infection, is
Yeah.
more. But no, I'm expecting, what is the technique? What is the long-term result? How is the patient improving?
Mhm.
How far have you followed them up? These are all legitimate questions. But when I get that question about, are you concerned about the lordosis? That is obvious. This is not a genuine question.
No.
This is just, we want to show you your prowess, how you can measure the angles here. But that is the typical lordosis question, and justifying that either not helping this patient, or if you are going to do something, break that in 5 places so you can create that angle, and justifying that 40 to 70% risks on a
Mhm.
patient. This patient obviously has been rejected to get that kind of surgery. But even if this patient poor condition wasn't that bad and it would allow that, and if you're talking about 2 years recovery, we are talking about getting an infection and dying of it, rather than doing a surgery that we do every week. That surgery we did, patient had a
Yeah.
scoliosis, and that patient is walking, ambulating, ready. We
Ready
discharged
to
that.
go.
We discharged the patient today morning, less than 24 hours after the surgery.
Mhm.
That is this obsession with lordosis is very self-serving, and I think that's maybe something like anything in medicine and in life. It goes like a pendulum. It was a time that nobody was concerned about the lordosis, and we did lots of things that even in younger people that it really wasn't good.
Mhm.
Now, few eminent surgeons talk about the lordosis, everybody follows, and now we have this really devastating obsession with the number fixing. We have these number fixers, and I'm sure we will swing back, become more like what we should be.
Yeah.
Taking care of patient and patient symptom, fixing patient, not the number. But at least at this point, every second comment is, did you fix the lordosis?
It's always on there.
I have a question. So like we know I'm talking about, I guess, for our OLIF patient yesterday, who said 63 minutes. How much OR time would we add to their surgery case if we were to fix the lordosis?
That would be for that surgery.
Yeah,
doing
like
it
on
that way,
top of the
eight-
OLIF.
The specific one.
8 to 12 hours, depending on how many time you break the back,
Right.
in how many location, how extended up and down, and so on.
You're talking
Easily.
an eighth of the time,
Yes.
and what? I can't even say
And
the
the
fraction of the
Yeah.
decrease in.
50 times
Yeah,
more risk
there
of
you go.
infection,
So,
and a patient that would be staying in the hospital like 10 times
Yeah.
more, and at the recovery
and we talked about a cardiac
times more.
issue as well.
Yeah.
Again, for
Even
an
if-
hour surgery, we got cleared, everything was good and safe. For a 9-hour surgery,
No way.
no.
So
Even a 4-hour surgery, there's 3
yeah,
hours.
that
There is no way.
anesthesiologist would not have even
Mm-mm.
put the patient sleep for a
Nope.
4-hour surgery,
I
but he
agree.
trusted me. He knew, you remember
I
when I
heard you
told,
the stats.
and then
You
he said, I
convinced-
know.
He believed you. Yep.
No, but he said, I know, because we have done it together
I
before.
know.
So, and that enable us, and the statistic we have with this procedure, first of all, is not just my statistic. Everybody who does it this way no, sometimes surgeons are so alpha dogs,
Mhm.
they see the success of another surgeon as their own failure. If somebody's faster than you, that sort of is not really
Mhm.
good for them.
Yeah.
But I just go again and again, say it has nothing to do with what I do. It's a different way of me doing it that really delivers the result. Everybody on our service delivers the same result. I'm not a better surgeon because of that. I'm just doing a different kind of surgery that enable me to do that.
But
But they take it as a personal insult that the surgery that they do in 8 hours with a 70% risk of infection can be done with me in 1/8 of the time, and with the stats that
You
I
know,
deliver.
that it's not even, the alpha dogs, because what you had just said is you were hoping people would say, tell me about this procedure. What did you do? How did you make this happen? And that's what you expect. I say this lightly, but successful surgeons
Yeah.
should be doing. They should be
Yeah.
researching. They should try to perfect their flaws in any way they can. But instead, they're trying to create flaws on your name.
Yeah, yeah.
So
The only-
that's the
yeah.
difference between, what makes you a great surgeon versus good surgeons is, you're not spending your time trying to discredit somebody else. You're spending your time trying to build your credit and help, your future.
He's focusing on the right thing. He's focusing on the patient, where other
Right.
doctors are more
Fo-
focusing on their
On his
And-
patients too, for the
Yeah.
wrong reasons.
Yeah.
Yeah.
So,
Now, I have offered even my competitors here in this town to teach them to that,
Mhm.
because like I can give you an example of Salk vaccine for
Mm.
polio. He just gave it to the entire world. He didn't want to patent it because he knew what it really means. Until then, we put these kids with polio in an iron lung. You probably don't know even what it is. These people have long muscle, their long muscles in the intercostal region, they are so weak they couldn't breathe. You put them in a box made of iron, and then with negative pressure, we help
Oh.
them to breathe.
I've seen photos of them.
Horrible. Now, he knew what the consequence of what he has is. He said, I cannot ethically just sit on it and let one company, and so he gave it to whole world. The same way I'm telling you, invite anybody in those hospitals that, we go and say, come, I want to teach you. I want to,
Mhm.
and you know what some of their response
They
is?
never have time.
No, but
They're
because
too
they do
busy in
it,
their 8-hour cases.
they're-
yeah, right.
and and I offered them, to show at my data, and some of the answers you got that. What do you, if I
remember-
ever develop an interest in your data,
I'll reach out. Yeah.
I'll reach out.
Yeah, but didn't you send him home early one day? 'Cause You
Yeah,
were so
yeah.
fast.
So that the story is that, the story is that, in the time they have opened the surgery, we are done with the surgery. So our days are much shorter, so they can use our rooms for their third
Their
case,
long
and
case.
instead of staying there for until 9 p.m.
I know. Look at, and you made it so effective for the rest of us. What time? We were done with surgery by 2
By 2
o'clock
o'clock.
yesterday,
By
and I
2
had to
o'clock.
come into the clinic
Yeah.
because my day was still going.
But do you
Come and
know,
talk to
Come
me.
on.
but do you know that the idea there is that what is the difference between that 1 hour and 8-hour surgery? What are you doing in the rest of that 7 hours? You're traumatizing the tissue. It's not our benefit that is really
Right.
number
No,
one.
correct.
It is the
Patient.
benefit that the patient get, and
Correct.
we have metrics on that. There's a study based on a meta-analysis of lots of studies for almost 400,000 patients. And they measured that every additional half an hour on the anesthesia adds 17% to the combined risk of the surgery. And that explains the entire thing, because in that, the rest of the time, you're cutting the tissue, you're burning the tissue, you're causing trauma after trauma after trauma. And these people, they think I'm rushing the surgery, whereas it's just a different surgery that it's not really rushing the surgery. But that's okay.
You don't have to cut those muscles. You don't have to go in and do all that
Yeah.
meticulous. Well, you do a ton of meticulous things,
Yeah.
but all that extra stuff, that's why it doesn't
And
take 8 hours.
I think I was critical of this 12 years ago, but I didn't just say, oh, I can't believe that. I said, I can't believe that, but I really need to go and watch this. I really need, and that's what I did.
Mhm.
I think it is the academic laziness is saying, this is too good to be true. But I'm not even going to look at the data. I'm just going to go and cut the spine in 15 places to correct the lordosis. And
Thank goodness.
So the lordosis, coming back to that, what is lordosis? It is a metric, is a certain bending of the spine that is that actually doesn't really apply to babies or anybody else, but the human, where we walk upright, and it has to have certain number to give our spine the maximum benefit. And based on studies, that is a certain group of people, those numbers matter. And now there's some surgeon think they can, first of all, transfer those numbers to completely different group of people and fix only that. I'm really looking for a time that we come back and say, how is the patient doing? How is patient daily activity? How is patient ambulation? What are the perioperative complications? Can you imagine that if we had 4 to 7 of our patients, those horrendous complication, can you imagine that? I mean, literally my risk of infection is 0.3%. 3 infection in 1,500 patients, and all of them, not a single take back to surgery. All of them reacted to the 5 days of antibiotics, get even better. Those 3 patients had extraordinary circumstances. Like one of them has some rheumatoid disease that lost 28 pounds in 4 weeks, and another person had like a higher BMI, smoker, diabetes,
slow.
and so on. And all of these 3 cases, they had extraordinary circumstances. Now, can you imagine if I had even close to that kind of?
We'd be shut down a long time ago.
Yeah, we would be.
The people on LinkedIn would be eating you alive.
Lordosis.
He'd be on LinkedIn saying, what about the Lordosis?
Yeah, you'd be on LinkedIn being all defensive, like,
Yeah.
oh, well, your images aren't that great.
Oh, yeah.
He'll be like, so you fixed the Lordosis? Why would you do
Why
that?
would Now, that's another hallmark that, I put all my data there. I spend so much time to refine my data, my patient care, whereas some people, it seems to have a lot of time to go and find what else other people could do better.
Even if, I won't get into it, but even non-surgical stuff, like going on Instagram.
Let's get into that. When they go and
mention the name.
No. When they go, that literally, how do you say that? If almost follow you on all your social media.
Fan energy.
It is fan energy. They follow
What
you.
is fan
Not
energy?
Fans, like, they follow me on everything and they want
But
to
it's
see
a
what
negative
I'm doing.
thing.
But
It's a
no,
negative.
Fan energy means that's how fans behave.
Oh, wow. Okay. So, no, I'm just wondering, I wish instead of spending all that time on this, go look back, if those data that you are using truly apply to all cases everywhere, or come and see what I'm doing. I gave you the option. I said I put you in our concierge. Come and just see what we are doing.
Since I've been here, I have not seen one person that's come and watched a surgery or a lab for the very first time and not just been in awe.
Right.
Like everybody, they know the data, they know the hours, they know this and that. And for example, we just opened our surgery center and we just hired a new charge nurse. And she said she spent the world in spine forever and ever. And she was so excited to watch this first case because she had heard the data and she just didn't quite believe it, And we got done and I looked at her and I go, so that was it. And she was just like amazed, And it's that same thing that it's like, we can tell them, we can video and show them. But the second they come and they see it, it's just, I love that reaction.
And it's okay to be a skeptic. We've had skeptics come.
Absolutely.
Our doctor from another country, he's our friend now. When he first came, he was pretty skeptical, and actually he didn't
tell you. Can you blame him though?
No, of course not.
I get it. I get the skepticism.
When he went into the OR, he started his own timer because he didn't believe us. And now Now you guys are cooperating. We've
Huh.
gone to
Yeah.
his country to do cases.
And even,
That's
I
fun.
think even more important is the idea there is, when you concentrate on what really patient wants rather
Mhm.
than what you want, if you don't have to do all that damage to get the job you want done, rather than patient want just to walk and so
Yeah.
on, you can achieve so much more for the patient rather than for your CV that I did that big
Yeah.
surgery from thing and so on. And in many of these cases, more is not always better.
Right.
And
A lot of
Most of the time it's not.
Yeah.
yeah, and if you look at our data, we did a scoliosis surgery yesterday. Patient less than 24 hours, already on the way home. That patient was smiling, sitting there, making
So
joke with
happy,
us.
got a coffee, life was
Yeah.
good.
And the concern was about eating and going home and so on. The concern wasn't, you still have a drain out of you. We have to transfuse you in the next few days few more times because
Oh.
it's going to still drain out of it with the risk of infection of 15-20% and so on. So this is if you concentrate on the minimum, being a minimalist, the
Mhm.
patient directly get the benefit. But if you concentrate on the number, your whole goal is to correct the number as an indication for future outcome, then you practically put the patient through much more trauma. Now, my question as well is, why should I get a number as an indication of the future outcome where I'm looking at the future outcome? I follow up the patient as long as I can to get the outcome. You're looking for an indication for that number. I follow up the patient, I measure the outcome.
Mhm.
We can do that. It's more work because, contrary to other surgeon, I have 28,000 follow-up on this patient that we have done surgery. I do probably 3 times more than average surgeon follow-ups to see actually how the patients are doing, but it's easier to just correct the number because the number you can just get X-ray after the surgery and then you're done.
Mhm.
Oh, I correct the number. Even if it didn't work, the number was good. So it's something else.
Yeah, and then they probably make the patient feel crazy and make the patient feel like they have issues.
Some do,
because-
not
because
everybody. I think most of surgeons have the decency, not to do that. But yeah, you are right. Some do.
afterwards is what I meant.
Yeah, that's what I'm saying. Some people some surgeon truly then say, numbers are good, X-ray looks good, and you have psychosocial issues
Yep.
and so
Yeah.
on.
Bye.
Yeah, but I think I give most of my colleagues the benefit of doubt that is not a typical thing that how we behave. We are better than that.
Yes.
Yeah.
I also like to think that would never happen, but I know
Yeah.
I'm not that naive.
Yeah.
I'm working on
Yeah.
it.
Well, Lordosis, you are
Thanks for joining us, Lord.
you're cordially invited. My house is your house. Come and watch what we are doing.
Not
And-
even just for Mr. Lordosis or Lord Lordosis.
Anyone.
Anyone.
This is a general public thing.
Yeah,
I'd love to see ya. I'll give you a tour.
yeah. And I think this has truly, that's how we have impacted, and patients are smarter than ever. There is an old story. Well, it's old now, but you guys are probably too young even to remember that. There was an Australian doctor. His name was Barry Marshall. And I often say that, remember Barry Marshall.
Mhm.
Heard that.
Yeah, about 50 years ago, now we had some disease that was deadly. It's called gastric or duodenal ulcer. You literally, you would have a hole in your stomach, you would bleed out and you would die. The correction, the treatment for that was going there, cutting your stomach out. And until then, we really didn't understand. We thought it is just too much acid, too much this, too much that. And the only solution was for us to cut your stomach out. Barry Marshall treated many of these patients and found out all of them have something in common. He found a bacteria that turns around, so-called Helicobacter pylori, that it's common. He postulated that maybe it's an infection disease. And he found out if he gives these patients literally antibiotic,
Mhm.
they get better. And they did. He had data. He went from conference to conference. This is unfortunately happened. He was laughed off the stage. He was not invited to talk in those things and so on. But it took him 28 years and until he proved to the whole world. He got a Nobel Prize for that because of his
Should.
perseverance for that. So, okay, keep my Nobel Prize warm. Okay, now,
Yeah.
but you know, finally what he did?
What do you do?
He ingested Helicobacter pylori.
He
He infected himself. He got a biopsy of himself. He got gastric ulcer, and then he treated himself with the thing. So he went to the extreme because people just couldn't wrap their head around what we have these hospitals only doing this.
Mhm.
They have like $1 billion industry cutting people's stomach out with the mortality of 10%. 1/10 of those patients died.
So bad.
And
Not even to mention all of the issues that come with taking out your stomach.
yes,
Yeah.
and instead of giving 3 doses of antibiotic, 3 days of antibiotic, rather than cutting your stomach out with a mortality of 10%. Do you know how many people died in that 28 years until they finally accepted this is a infection
Lot.
disease? Yes.
That's really sad.
1 in 10.
This is,
So
you almost
let's
lose
see.
your trust in humanity when you see that, you know, and all they needed to do to truly, genuinely look at his data. Now, do you know what is our advantage now?
What?
We have social media. The patients are smarter than ever. They have access to the data. All those patients are already canceling their surgeries with those doctors that are coming to us. And because the data is there, you just have to open your eyes and
Well, what is one thing we almost require our patients to get a second opinion
absolutely.
because
That's a
we
requirement.
want them to go and talk to somebody else and see, you know, what they have to say and what they have to offer. I have several people that come in with their own sort of pamphlets that they got from whoever, and they say, "What do you know about this?" And I go, "I don't know much, but I know what I know is about what I can offer you."
Mhm.
And nothing's comparing.
Yeah.
I
And-
can tell them that.
Yeah,
Right.
I think everybody hears our passion about this in our conversation today, and I think as well that sometimes maybe you more than other people see my frustration. Then people are told that our patients are told there's nothing can be done for them, or some people as well say, you know, that if that's all what's left in life, I don't want to live. And I understand that, you know, if you cannot do anything, and, you know, even younger people say, you know, I cannot do anything with my family.
Mhm.
And then they come here, we do that 1-hour surgery,
Yeah.
they get their life back, they walk, they are off narcotic, literally off, they've been on narcotic for years. They're off narcotic, and then I put the pictures out there, and somebody asked, what about Lordosis?
Mhm.
And then you just laugh.
No, well, I wish I
You
could laugh,
always
but-
write a nice response.
No, I
You
always
Should laugh.
You
Just
can come
laugh.
and visit us. I'm happy to get online. You always send a nice response.
Well, this is the nature of what we are doing, and medicine is conservative, and I try not to get that personally, but it's hard if I see that that's truly impact on people who matter, the patient, and because spine is not a rare thing.
Mhm.
By the time you're 70 years old, and this is mostly problem of 70 years old, there is a 1 to 2% chance you don't have spine problem. And there are lots of people that, you know, their end of their life is just a pure misery by us concentrating on numbers rather than the patient. And that's unfortunately a daily occurrence. It's hard for me not to take it personally.
Don't even get us started on numbers.
Yeah,
We could
yeah.
talk all about our BMI patients and our
Yeah.
age, and that's a whole nother thing, but
Well, I think we have said what I have said what I have to say.
Yeah, me too.
I could go on.
Thank you guys for watching. This is Essence of Medicine. What is Lordosis? I'm Amanda Armagost.
I'm Melissa Haber.
And I'm Dr. Abbasi for Essence.